The year was 1996, and Christmas was just around the corner. Thousands of children all over the United Kingdom were asking Santa Claus for one precious item: a Buzz Lightyear action figure from the Toy Story movie. 25,000 buzzes, that's the collective term for Buzz Lightyear's, buzzes, were loaded onto a container ship bound for England. But then disaster struck. The container fell off the ship and into the sea. How did this happen? Did 25,000 action figures make a collective bid for freedom and dive off that ship? Did Santa Claus himself swoop down and take those items just a few weeks before Christmas? Or was it a freak wave? We will never truly know. Like many supply chain challenges, it was both unexpected and somewhat inexplicable, and it threatened to leave 25,000 children and their very, very interested parents in a terrible situation. Now, I was working in a team in commercial supply chain at the time, and I was called in to troubleshoot. Working with the toy company, we found a surplus consignment of buzzes in Singapore, and we moved them onto a ship with expedited delivery, and the expected delivery date into the UK was the 24th of December, Christmas Eve. Myself and my team were in a state of high anxiety through those weeks, but we went down to the port of Southampton dressed in our coats and our hats and our scarves. It was snowing rather appropriately, and we saw that container off the ship, and we saw it onto the back of trucks, and those trucks went to toy stores, and those concerned parents picked up those toys, and those Buzz Lightyear action figures arrived under those Christmas trees in time for Christmas Day. A very happy ending to a very stressful story. But 30 years on, with so much more experience in supply chains, I can't help but thinking, if only supply chain challenges were this simple to resolve. Now, over these past 30 years, healthcare supply chains have gone from somewhat dispersed national networks to highly integrated, cost-optimized global networks. And that optimization has brought great cost savings, great standardization in terms of quality, but also some fragility. Some fragility in terms of shortages, some fragility in terms of dependence on a few manufacturing locations, some dependence when we have disruptions during pandemics. Now, indeed, you might remember when COVID hit the world, one common image that the media published on repeat looked something like this. When it came to family planning, COVID led to clinic closures, travel restrictions, diverted health staff, and overwhelmed facilities, making it much harder to get both short-term and long-acting contraceptive methods. 12 million women in 115 low and middle income, 12 million women in 115 low and middle income countries experienced disruption in their family planning services, leading to about 1.4 million unintended pregnancies. And many of the most affected areas were those lower middle income countries that had somewhat weaker supply chains. RHSC sprung into action during COVID. Our members moved in a matter of weeks to address these supply chain issues. RHSC commissioned several studies to learn from the experience of COVID to make our supply chains stronger. We wanted to make recommendations on how to future-proof those supply chains. We talked about regionalization of those supply chains, diversifying financing, and those intricate in-country workarounds that would help in those desperate times. We looked back, we learned our lessons, and we moved forward. We never dreamed that just a few short years on, our community would face another global catastrophe, and one that we would not be prepared for. We fast forward to January of this year, when the US government made that shock announcement that it would freeze nearly all foreign aid through USAID, including programs supporting reproductive health. By the end of a 90-day period, nearly 12 million women and girls were thought to have been denied essential reproductive health care. So why are we here today in this auditorium? My fellow storytellers and I are going to take you behind the scenes to really look at the reproductive health supply chains most of us take for granted. What makes them tick? What makes them vulnerable? How can we strengthen and sustain them? And how can we make sure that that nightmare of the opening months of this year never happens again, where we were caught so unprepared? So before we begin, a word of reassurance. Yes, we are going to talk about logistics, but we're not going to bombard you with jargon. You won't hear multimodal distribution optimization leveraging predictive analytics. You won't hear sustainable sourcing alignment with ESG objectives. You'll hear about the community's shock, disbelief, and despair that steadily evolved into innovation, ingenuity, solidarity, and ultimately hope. We will piece our stories together to pave the way for a future where there is more choice, more access, and more agency for women and girls in lower middle-income countries. And so we turn to our first storyteller, and we open with a story about disbelief. What does it feel like when things happen outside of your control, when abrupt funding cuts disrupt every supply chain certainty that you've come to rely upon? Mukul Taparia, the managing director at Pregna International, knows this. Mukul's a long-time supplies champion, a former manufacturer's representative on RHSC's executive committee. And so, Mukul, thank you so much for agreeing to share your story with us. Can you please take us back into January of 2025, take us back into a time when the factory floor fell silent? Thanks, Mukul.
Can you hear me? Okay, yeah, that's good. So to introduce myself, I'm Mukul Taparia. I'm the managing director at Pregna International Limited. Pregna is a manufacturer based in India, supplying reproductive health products to more than 140 countries. And we have had this great relationship with many donors, including the UNFPA, USAID, Gates Foundation, private distributors, Ministry of Health, and this has been a relationship over more than 30 years. Now, because pharma companies work in such complex and regulated and uncertain environments, we are very good at our due diligences and risk assessments. They're a key part of how we plan our processes, our production, and how we make our decisions. We keep a close eye on the market conditions, government policies, and to spot threats early. We periodically run what-if scenarios, stress tests, and contingency plans. So early this year, in Jan, we were fairly calm. We felt that we had everything in control. And we are feeling good about ourselves, that we are prepared for any reasonable eventualities. Any reasonable eventualities. So nothing could have prepared us for what was to come and get us into an absolute chaos that we were plunged into. I still remember it was the 20th of Jan, a pretty calm and normal day, and someone had read on Twitter that the USAID program had been frozen, as was under evaluation. Now really, who trusts posts on Twitter and WhatsApps? Would you? We thought it was probably some sort of an internal audit which was going on while the program was going on and it was continuing on. So we dismissed it. Pregna had actually enjoyed a long-standing 3-decade relationship with the USAID program. And to the extent that in few of the years, we were the sole supplier of IUDs. We were actually partners. and we understood each other very well. So nothing bad was going to happen to us, and not to us anyways, right? We had orders in the pipeline, and there were some goods which were ready to be dispatched and picked up by the freight forwarder, and there were some other goods which were in the manufacturing department. The freight forwarder was delaying the pickup of the goods, and we were really wondering as to what's going on and why it's happening. A few days later, we received an email from PSM saying that the order was on hold. Now the team was a little worried, but we were still rest assured that it was just a matter of time before the goods were going to be picked up again. After all, what is more safe and a reliable order than one coming from the USAID implementing partner, right? But that was just the beginning and tip of the iceberg of a slowly unfolding nightmare that 30 years in business had not prepared us for. With each day of inaction and silence, our hope dwindled a little bit. Days went by with no responses. Our emails went unanswered. There was complete silence. This after years of working together, and now this is what we get. We were really scared now. People were unsure about their jobs. The order was canceled. The contract was canceled. And we had no idea absolutely as to what we were going to do with those goods. It was actually very hard to process these feelings. We were in a state of shock. We were angry. And we were actually evaluating our options as to what we can do now. Some people advised us that we should seek legal action. But then we soon realized that the contract provided for cancellation without recourse. I had never thought in my life that this clause would be invoked during my lifetime, but it did happen. So then we started looking at other options as to who could be the other customers who would be willing to take on these goods. USAID had a specific requirement for shelf life and labeling, and this did not match with the others. These goods were actually destined for DR Congo. So we thought that, there is a need in DR Congo, so might as well ship those goods to DR Congo. So we spoke to our private customers and convinced them to receive these goods. They were agreeable. In our enthusiasm, we went ahead and relabeled the boxes for the new consignee. That was a big mistake. The brand registered with the consignee was different, and they were unable to receive these goods. Discussions started with the other customers and from other countries, but with each passing week, our desperation increased. The goods were clogging our warehouses, and we had no idea as to what we were going to do with those. Then we got a confirmation from Kenya that they could receive these goods. So we repacked and relabeled again. Little did we realize that the USAID funding cut had created other issues. Kenya's family planning budget had been diverted to other emergency medicine procurement. So now we are back to square one. So the team started working on breaking down those quantities into smaller volumes to ship those goods to other customers. The factory was advised to break down the pallets, but we got limited success. The story went on and on. Then we got a good news. One day, UNFPA agreed to receive these goods in Nigeria. By this time, the factory team had lost all hopes with the marketing team. So I got a call from my exasperated plant manager asking me, "Sir, are we really sure this time?" And the only way I could reply to him was, "We hope so." The goods finally moved in mid-September 2025, which was 8 months from his original plan. We had invested in these products for more than a year now. Did we make a profit after 7 relabelings? Probably not. But then definitely there is a huge sigh of relief thinking about that we have been able to get these goods to the women who needed them the most. These products stand to generate 1 million CYPs, yet went through unimaginable delays beyond anybody's imagination. This experience has actually opened our eyes. While this was unprecedented, unexpected event, we realized that post-COVID era, and with this changing geopolitical situation, the supply chain continues to remain very fragile. So what have we learned? Number 1, standardization of product labeling across various geographies and countries can go a long way in mitigating risks. Number 2, it's not done till it's not done. Until that moment when you get your product to the final consumer's location, you need to be on your toes, tracking every movement and every step. Number 3, visibility, predictability, and forecasting continue to remain key areas to be strengthened within the supply chain. So now looking back, I realized that it took us at Pregna quite a long time before we realized how harsh the US government actions really were and how badly our community would be impacted, not least the end users. But over in Kenya, it was a different story. Civil society was probably well prepared and ready for the negative impacts as soon as the Trump government was re-elected. But even in Kenya, in that same month of Jan, many were devastated by the executive orders that paused and potentially cut all funding assistance. So I would like Nelly Munyasia from Kenya to tell us more, and I'd like to hear from her how Kenyan advocates, however vigilant they were still not ready for the brutal reality. Over to you, Nelly.
Thank you so much. And so, the global gag rule wasn't the worst part. Kenya's wake-up call on SRHR financing. No stocks, no clinics, no choices, just the return of preventable suffering. Does that sink? Do you resonate with that? The month was January, the same month that our colleagues from Pregna were playing their waiting game, as he has correctly put it. I mean, we all had just gotten back from our festivities and adjusting to a new year. And we were all working on our work plans, setting targets, and very excited about the year. Of course, with the economy being what it was, and especially in Kenya, the finance people were trying to readjust budgets and dealing with the inflation. Trump had won the election. And so, of course, it was part of our advocacy agenda. And for some of us that have been around since 2018, we had continuously planned and prepared with our partners, what if Trump won? And of course, ours was around SRHR and provision of, abortion services. In every room you went to, if people were silent, you only needed to say Trump, and everyone would nod. And all opinions will come up with everyone giving their own predictions and the next steps. Did anyone ever imagine what the prediction was going to be? Definitely no. And this included governments that were very comfortable and knew that it was business as usual, and more importantly, with Trump as a president, then they were going to continue getting what they used to get. Mid-January, social media was going wild. And the focus was mainly on the anticipated reinstatement of the global gag rule. No one anticipated that it was going to be a stop order. Meetings had been held prior to the announcement by stakeholders, especially, like I said, those of us that work in the SRHR space and those of us that had been affected from way back in 2018. And of course, the partners working around family planning and contraceptives, we all knew, we followed the electioneering period, and we knew what Trump stood for. Of course, strategies were in place. We had formulated very beautiful strategies on how we were going to counter the impact, just in case there was a reinstatement of the global gag rule. Articles were already released. We were signing on to global articles. Nationally, we were writing our own articles and just, trying to highlight on what a Trump presidency meant, what a reinstatement of the global gag rule meant, and all this information was outside there. But like I said, everyone predicted this, everyone was prepared for this, the global gag rule. What a majority did not anticipate was that the president the president-elect, Donald Trump, would issue an executive order, and immediately with a 90-day pause on foreign assistance. What did this mean? Someone needed to clarify this because there was no president, unlike the global gag rule that we knew what that meant. No one, even the jargons, the people in advocacy, the people that worked really directly with, in the United States, none of them had this right because this was not prepared for. And therefore, there was no preparation, there was no planning, and certainly no jargon or abbreviations to explain what had just happened. And that order included immediate suspension of all foreign aid from the US. And this was issued to all implementing partners. None of them was spared. What did this exactly mean for my beautiful country, Kenya? Kenya, my beautiful country, is ranked the 5th highest beneficiary of the US assistance, having benefited for over 60 years. I probably even never knew I would be on this stage by the time my country started getting the support from the US. And between 2001 and 2024, Kenya had received US support of about 1.26 trillion. 1.26 trillion. And among the programs that were supported, including family planning through UNFPA, HIV programs through PEPFAR, and at 2024, approximately 6.43 million Kenyan women were using modern contraceptive method, preventing an estimated 2.42 unintended pregnancy, averting 602,000 unsafe abortion, and saving about 10,000 maternal lives. The freeze stopped the delivery of life-saving HIV medicine and prevention services that impacted many Kenyans, although in February, PEPFAR was granted a limited waiver to resume urgent life-saving treatment. What about other cases? What about the women that relied on the family planning services? And we think about the women that at that time were going back to their refill. Picture this, in my country, they are all queuing at the health facility, and they are all waiting for their refill. They are going for their 3rd month DMPSC. They are going for their IUD. And just to get to the healthcare provider, they are told, sadly, we do not have the commodities. Didn't you hear about the USAID funding cut? And the woman is looking at you and wondering, what exactly are you telling me? What is USAID funding cut? Who is Trump? They have no idea. And let me paint a clear picture. Before all the interventions around HIV and reproductive health services, many women and girls had to seek services from quacks, what we called the unskilled providers of health services, and backdoor providers. These services include getting herbal mixtures to stop abortion services. It includes a woman having to be stepped on the tummy when she's pregnant so that that pregnancy can be expelled. And you can imagine what comes with that. And you can imagine also the stigma of if you are on diet and you're working on your weight, someone looks at you and they say, that one is thin, she or he is HIV positive. And so with all this, and as an organization that has worked with women and girls, an organization that has experienced women coming to our facility to seek services with ruptured uterus, infections, bleeding almost to death, what did we do? So I work for Reproductive Health Network Kenya, which is a local non-governmental organization in Kenya, working with providers to ensure that we save the lives of women and girls in our country. And so we quickly came up with strategies to mitigate the impact that was heavily felt post the USAID shutdown. Of course, we worked very closely with government, and one of the things we did was to provide redistribution channels of commodities through our social enterprise, and really grateful to some of our funders that provided support for commodities such as hormonal IUD and DMPSC, which we are seeing a lot of women and girls, choosing it as a method, and because of the longevity and it being very modern and long-term, but also the fact that for DMPSC, they can self-inject from the comfort of the home as long as they have the commodities. And so specifically, I want to mention the IPPF harm reduction funding that came in timely, and we were able to work with governments, with sub-nationals, and we identified areas that had been hard hit, and we conducted outreaches. And these outreaches were purely family planning. And one incident is when a woman told us in one of the regions in Kenya that she had come to the facility 4 times and she had not accessed the service. And when she was told that RH&K was going to conduct an outreach, she had to travel for miles just to come for that service. And this is because of the empowerment that had gone in place over the years before the stop order. This is reactivity, colleagues. This is definitely reactivity. What about proactivity? The funding cut has exposed serious gaps in our supply chain. It has revealed just how much we are donor dependent for essential services that are life-saving. It has shown how many of our programs lack sustainability, unfortunately, and are one politically biased decision away from shutting down completely. If you asked a young girl from my village who accesses services from a closer healthcare facility, who Trump is, they have no idea. But a decision that was made back in the US has impacted her life. It's therefore time for us to unite as public, private, and non-governmental and come up with sustainability models that go beyond government, that go beyond donor funding. The government can align their human resources and hire, for example, the staff that were PEPFAR supported and ensure that they are supporting in provision of services, but also the community health promoters to continue with the great work that they do in the community. Total market approach that brings all stakeholders together remains a very critical component of us mitigating all this. Colleagues, no one is coming to save us. We must save ourselves. And countries in the past have shown that they can do it. And for that reason, I want to invite my colleague Nora Kuseda to show us which countries have broken free from political tyranny and live to tell the tale.
Thank you. Well, yeah, think like water. And at the end of my story, you will realize what I mean by that. At the dawn of the 1990s, Mexico stood at a decisive crossroads. For decades, the family planning program had relied on the steadfast support of USAID, which supplied reproductive health commodities and delivered technical assistance to both the government and two experienced non-governmental organizations, MEXFAM and FEMAP. Then came a pivotal shift. USAID launched the Graduation Plan, a 5-year strategy designed to gradually transfer full financial responsibility to the Mexican government. Nobody expected that. Leadership would rest with two central institutions, the Mexican Institute of Social Security and the National Center for Gender Equity and Reproductive Health. Until that moment, family planning in Mexico had often been perceived as a program shaped and steered by foreign cooperation, especially by the United States, concerned with high fertility rates across the region. The Graduation Plan provided Mexico the opportunity to break with that dependency and take ownership of a program fundamental for its development. The commitment was bold. Each year, the government pledged to finance an additional 25% of contraceptive commodities, aiming to reach 100% by 1994. Yet the challenge was incredible. While the Mexican Institute of the Social Security and the National Center for Gender Equity and Reproductive Health were recognized leaders in delivering reproductive health services, their logistical capacity to manage contraceptive supply chains was still weak. The risk of supply disruptions was significant, especially in a decentralized setting where each region had to manage its own budget for health commodities, including contraceptives. To Pablo, a logistician assigned to the management of the National Center logistics system, the supply chain was not an abstract concept. It was an underestimated network of people, boxes, trucks, maps, and time, all of it under pressure. The task was clear on paper: move millions of units of contraceptive products from a decentralized warehouse to over 8,000 rural and urban health facilities across the country. In 1990, the system looked like this. All procurement ran through the Mexico City. Commodities arrived at the central warehouse, sat for weeks in customs or in overfilled storage, then was dispatched in large, infrequent shipments to regional health offices, if transport was available, of course, and paid for by the regional authorities. Inventory records were handwritten or stored in siloed government databases that rarely match field reality. Forecasting was a guess. Reporting was delayed. Buffer stock, that was a luxury no one budgeted for. Pablo's team had 3 years to make this system reliable. Not perfect, but reliable enough to scale a 25% increase in contraceptive volumes every year with 0 increase in delivery delays. Think like water, his supervisor, Yvette, used to say. Flow where resistance is lowest, and where there's a blockage, carve a new path. Pablo started with mapping, literally. He led a small team that collected inventory data on every facility receiving contraceptives, from massive urban hospitals to one-room clinics in highland villages. Each point on the map became a node. Then came the transportation links, government trucks, rented trucks, contracted couriers, you name it. They built what was at the time the most comprehensive supply chain visualization the Ministry of Health had ever seen. The first insight: the system was not failing because of a lack of products. It was failing because no one knew where the product was. Pablo's system was primitive. Simple Excel uploads sent weekly via modems, but it exposed a brutal truth. 28% of the clinics listed as fully stocked were experiencing actual stockouts. Data latency. Pablo said, we're making decisions 90 days late. So they pushed for the centralization of procurement and decentralization of data, allowing for a push system where the central level could determine how much to deliver to the regions. The plan met resistance. Bureaucrats fear losing control, and regional managers fear accountability. But the numbers won. It took only 4 months to see the results. Clinics that were previously stocked quarterly were now receiving monthly shipments. Emergency orders stopped or diminished. Wastage from expired products fell by 40%. But success also brought new problems. As inventory turned faster, procurement needed to be more precise. Forecasting errors became more visible and more costly. That's when Pablo and his supervisor, Yvette, realized the need to train nurses, doctors, and other staff at the central and regional levels in basic supply chain management principles, and to develop a sense of ownership for the family planning program. Pablo, with assistance from supply chain experts, developed a training curriculum in supply chain, including a new forecasting model based on historical consumption data, adjusted for seasonability. Yes, even contraceptives have peaks, linked to harvest cycles, migration, and clinic outreach campaigns. He and his team trained regional staff in how to use the new model. Forecast accuracy improved from 63% to 87% within a 3-year period. By mid-1992, the supply chain was no longer the weakest link. It was becoming a model for other health programs, vaccines, essential medicines, even surgical supplies. In 1993, when the government reached 80% of contraceptive finances, the question was no longer whether the commodities would be paid for, but whether the supply chain could deliver at scale. The answer was yes. Delivery frequency has doubled. Stockout rates were under 5%. Clinics that once waited months now receive automatic replenishments every month. By 1994, the system was almost ready. The government hit 100% financing. For the first time, every contraceptive commodity provided through the public sector was paid for, tracked, and delivered through a national system that was smart, responsive, and resilient. And now there were systems, buffer stock, contingency plans, trained staff. Most importantly, there was trust in the program and the system it managed. Trust that when a clinic placed an order, someone, somewhere in the invisible network would deliver. Because in the end, that's what a supply chain is. Not just a flow of goods, but a promise kept on time in a box. The biggest lesson from this story, thinking like water, is about adaptive leadership in systems change. The ability to move with challenges rather than against them, and to build resilience by flowing through resistance instead of fighting it. Pablo's story shows that success didn't come from having more resources, but from rethinking how the system moved and how the graduation plan gave the government of Mexico the opportunity to demonstrate their capacity to overcome challenges. By mapping, listening, and iterating, he and his team transformed a fragile paper-based distribution change into a reliable national system. In doing so, he demonstrated that resilience is built not by rigidity, but by flow, by continuously adapting to reality. What you all could learn from and apply from this story: flow through resistance. When you meet barriers, political, structural, or human, don't stop. Start with visibility. You can't fix what you can't see. Pablo's first act, mapping the system, turned invisibility into insight. Build systems of trust. Reliable supply chains of any system depend on trust. Trust that the process works, that data is real, that people deliver. Empower through knowledge. Training others and decentralizing data ownership turn a fragile system into a resilient one. Capacity building isn't an add-on. It's the backbone of sustainability. Measure progress in promises kept. At its core, every system, health, education, humanitarian, is about delivering our promises. Most remarkably, this foundation endures. By 2025, more than 30 years later, the supply chain designed during the graduation plan remains operational, continuously updated with new technologies and practices, but its core design still reflects the foresight of that transition. Mexico's family planning program has thus become a benchmark, a clear demonstration of how a country can evolve from dependence on international cooperation to self-reliance and sustainability, safeguarding uninterrupted access to essential productive health services for millions. Mexico dug deep within its own resources to make this dramatic change possible. I'm going to invite Cletus now to tell us about exciting changes in an entire region and how the power of partners offers hope and promise. So welcome, Clayton.
Good morning. Good morning. Thank you. I need you to put your hand on because I'm speaking French. Are you ready to improve your French? Okay, thank you so much. My name is Cletus. I'm working with West African Health Organization. Je voudrais, mesdames et messieurs, que vous imaginez un monde où les voisins partagent. Un monde où vous n'avez pas du pain, moi j'en ai de trop, et je partage avec vous mon pain. Ça fait que vous ne dormez pas faim, et moi également je ne gaspille pas la nourriture. Mais malheureusement, ce principe simple de solidarité, d'amour, je dirais d'équité, qui contribue à notre bien-être collectif, est plus compliqué dans le domaine des médicaments. Parce qu'il faut beaucoup de coordination. Il faut de la confiance, parce que nous sommes en train de partager des médicaments. Il faut d'attention. Il faut de partenariat, de la volonté pour que ceci soit possible. Et vous savez pourquoi? Il y a plusieurs raisons. Et je vais vous citer quelques-unes. Tout d'abord, les règles nationales en matière d'enregistrement des médicaments peuvent varier d'un pays à un autre. Ensuite, le processus d'importation des médicaments varie en fonction du type de produit, de son utilisation, bien que les étapes communes comprennent l'obtention d'une autorisation de l'autorité compétente, une déclaration en douane et évidemment des contrôles de qualité. Aussi, certains médicaments nécessitent une chaîne de froid, principalement des produits thermosensibles. Leur efficacité et leur sécurité dépendant du maintien strict de températures contrôlées et le transport dans le cadre d'un échange entre deux pays de ce type de médicaments, sans garantir la chaîne de froid, risque de rendre ces produits inutilisables. On est d'accord? Par ailleurs, les pays peuvent avoir des règles strictes en matière d'approvisionnement, de budget et d'acceptation de surplus externes. Puis, les étiquettes peuvent être rédigées dans une langue étrangère ou indiquer des unités de dosage différentes. ce qui crée un risque clinique et une responsabilité juridique. Je vais m'arrêter là pour vous donner un seul exemple. Nous avons fait un transfert, que je vais dire un peu plus tard, entre le Niger et le Nigeria. Le Niger est un pays francophone. Le Nigeria est un pays anglophone. Le Nigeria a besoin du produit et on a transféré le produit du Niger vers le Nigeria. L'étiquette était de base en français, puisque les produits ont été livrés au Niger il y a peut-être 3 ans. Il fallait retraduire et réétiqueter les produits pour que la population nigérienne anglophone puisse utiliser. Voilà un exemple de cet élément-là qui complexifie l'échange des produits entre nos pays. Ma dernière raison, les pays donateurs peuvent envoyer ce dont ils disposent, mais pas nécessairement ce dont le voisin a besoin, ce qui peut entraîner du gaspillage. Voilà globalement, mesdames et messieurs, quelques raisons pour lesquelles c'est plus compliqué, plus complexe de partager des médicaments au lieu que nos pays souffrent. Notre organisation, l'Organisation ouest-africaine de la santé, a été créée pour faciliter tout ça. Nous avons été créés en 1987 pour l'harmonisation des politiques, pour la coordination des programmes, pour mobiliser les ressources et les répartir de façon équitable entre nos États membres, pour coopérer entre nos États membres, entre eux et les autres États du continent. La force de notre collaboration, de notre solidarité régionale, a été mise à l'épreuve pendant la COVID-19 et son impact imminent sur la chaîne d'approvisionnement dans notre région. Pendant la COVID, notre organisation, l'OAS, a joué un rôle essentiel en coordonnant les achats, la logistique et les mesures politiques régionales qui ont permis la circulation transfrontalière des fournitures médicales essentielles dans notre sous-région. Elle a acheté et distribué des équipements de protection individuelle, des kits de diagnostic et des équipements oxygénothérapeutiques avec le soutien de l'armée du Nigeria. Vous imaginez? Ce qui a permis la livraison rapide de nos membres alors que les voies commerciales traditionnelles étaient bloquées. Collectivement, ces actions ont permis de regrouper toutes les réponses nationales fragmentées au sein d'un système régional coordonné d'approvisionnement. Mesdames et messieurs, notre adhésion au VAN a renforcé notre coordination régionale en lui apportant une meilleure compréhension et plus de puissance. On se sent plus fort. Et pour votre information, l'OAS, notre sous-région, occupe 40% des participants du VAN au niveau mondial. Sous la direction de notre institution, le VAN a été intégré dans le système d'alerte précoce et est utilisé par tous nos membres pour offrir une visibilité régionale sur la sécurité contraceptive afin de prendre des décisions importantes en matière de financement dans notre sous-région. Cette intégration a ouvert une nouvelle possibilité pour les transferts de contraceptifs dans notre région. En 2023, précisément en décembre 2023, et si vous voulez la date, je vous dis le 11 décembre 2023, le Nigeria devait faire face à une rupture de stock au niveau central du dispositif intra-utérin, le DIU. Il a officiellement demandé à l'OAS pour un transfert de ce produit. Au même moment, le Niger était en surstockage du même produit. Le Nigeria est en rupture de stock anticipé du DIU. Le Niger a ce produit en surstockage dans son pays. Grâce à la coordination et au VAN, puisque toute cette information-là ont été recueillies à travers le VAN, 40 000 DIU à cuivre ont été transférés avec succès au Nigeria, comblant ainsi un déficit de financement critique et offrant une protection équivalente environ de 185 coupes années protection. Le transfert a pu avoir lieu avant que la situation ne s'aggrave, plutôt que d'attendre que la crise éclate. et le gaspillage a été réduit du côté du Niger, car l'expiration des stocks utilisés au Niger a été évitée. Donc, on a transféré le produit pour sauver des vies au Nigeria et on a évité le surstockage, du gaspillage de produits au Niger. Mesdames et messieurs, ce transfert du Niger vers le Nigeria, le Niger, c'est un petit pays, le Nigeria, c'est un très grand pays, il faut pas imaginer. Donc, un petit pays peut déjà donner du produit à un grand pays, je pense que c'est quand même très important et très fort. Un pays anglophone qui reçoit un produit d'un pays francophone, c'est aussi assez fort. Donc, ce transfert de produits est le fruit d'une collaboration entre l'OAS, la coalition, l'USAID, Bill et Melinda Gates, la KW et d'autres partenaires qui ont contribué à ce que nous puissions faire ce geste-là. Et pour votre information, ces dernières années, nous avons déjà effectué environ 15 transferts. Ce n'est pas seulement le transfert du Nigeria, c'est 15 transferts que nous avons faits. Mais aujourd'hui, l'Afrique de l'Ouest est confrontée à une crise similaire. Aujourd'hui, plus de 9 mois après la réduction du financement du gouvernement américain, les responsabilités de la santé, ou je dirais les responsables de la santé, signalent des tensions très importantes de stock de médicaments. Bien que certains pays aient tenté de combler ce gap en octroyant des fonds domestiques, la crainte est toujours là que nous sommes tous en tension de stock parce qu'un partenaire important s'est retiré. Ceci porte un frein à cet élan de solidarité. Vous savez pourquoi? Parce qu'aujourd'hui, quand un pays est en rupture de stock, l'autre pays ne veut plus donner parce qu'il ne sait pas s'il va l'avoir ou pas, parce qu'il n'a pas de financement garanti. Mais c'est le moment que nous devons être plus solidaires. Nous ne devons pas céder aux paniques, nous devons continuer cette action de solidarité. En effet, les pays hésitent maintenant à donner leur surplus. Et cette situation nous oblige, en tant que partie prenante, à agir. Cela signifie que nous devons utiliser encore mieux les ressources qui sont encore disponibles. Pour cela, nous devons nous unir et collaborer en tant que région, plutôt que de recourir à de l'isolationnisme face à l'inconnu. Cette confiance, cet engagement en faveur de la coordination continuent à rendre notre région plus forte. Nous devons investir dans l'amélioration des capacités régionales et nationales afin de tirer meilleur parti des données du VAN pour prendre des décisions éclairées et minimiser les risques tels que les ruptures de stock et les surstockages. Nous devons accélérer la mise en œuvre du système régional d'approvisionnement commun de la CEDEAO qui peut garantir l'accès des produits abordables, de qualité, sûrs et efficaces. Nous devons améliorer le processus d'enregistrement conjoint des médicaments de la CEDEAO pour des médicaments et des vaccins. Mesdames et messieurs, nous savons que nous avons les moyens d'y parvenir. Nous disposons de partenaires sûrs et nous avons la volonté. Pour aller en avant, nous avons maintenant et nous devons tourner vers le passé afin de puiser l'inspiration et l'élan nécessaire dans nos succès du passé. Et aujourd'hui, plus que jamais, nous devons nous mobiliser pour mettre notre vision et notre pouvoir collectif au service de l'avenir des femmes, des filles, des hommes de notre région. Je voudrais, mesdames et messieurs, finir mon propos en tournant vers l'avenir. Et je sais que mon collègue Yasmine partage la même perspective avec moi. Je voudrais l'inviter à partager avec nous son histoire. Yasmine.
Merci.
Je vous en prie.
Merci, Cletus. Thank you. I was encouraged to hear Cletus's story about the strong systems that good partnerships can put in place. My story comes from across the continent, more than 6,000 kilometers away in Kenya, and I also want to talk about strong systems that good partnerships can bring about. I'm offering us two ways to think about supply chains beyond trucks and warehouses and spreadsheets. To me, supply chains are the heartbeat of family planning and reproductive health programs. When they work, they are steady and rhythmic, they deliver products, gather information, and they save lives. At the same time, supply chains are also the threads of a fabric for a program. They weave together people, products, processes, data, technology, funding, and promises, like Nora said. They connect women in a community pharmacy to a distributor in a capital city, a regional manufacturer, a ministry policymaker, and a government treasury decision maker. But when a heartbeat falters, the whole body feels the impact. And when a single thread snaps, the whole fabric becomes weaker. When COVID-19 struck, our collective heartbeat skipped, and for a time, even stopped. Cargo routes froze, as you've heard. Borders closed. In Kenya and across East Africa, supply chains that had taken decades to build began to unravel. Our teen pregnancy rates shot through the roof, and we lost valuable progress in many health indicators. We saw where the threads were weakest. We were too centralized, too donor-dependent, and too far from where women needed care. But one place that the pulse stayed the strongest was in community pharmacies, especially neighborhood chemists. Community pharmacies became the threads that quietly held the fabric together when everything else was fraying. A community pharmacy is where most Kenyans go when they have any health issue. The last 2 weeks, for example, I've had 2 sick kids. There's been a bad flu making the rounds in Nairobi. My neighborhood pharmacy was on speed dial. I went there 3 times in the course of 3 days, and they delivered to me twice. The pharmacists know me, they greet me, and I'm literally in and out in a couple of minutes. And during COVID, pharmacies were embedded in the fabric of communities, adapting rapidly, adding home delivery methods, and adopting telehealth. Post-COVID, the Kenya Health Ministry began wondering, what if pharmacies became a legitimate, trusted part of the national family planning and self-care fabric? You'll remember from hearing from Nellie, my fellow Kenyan, she called for the total market approach as a promising solution in her story. Through support from the Gates Foundation in partnership with our government partners and other stakeholders, at InSupply we started to weave pharmacies into the family planning total market approach. It hasn't been smooth sailing. Shifting the mindset of our ecosystem to accept that the public sector is not the only place you can get quality family planning has been a journey. We had to align regulations and policies. We had to train pharmacy providers in counseling, choice, in how to inject, and we needed to help them build trust and client confidence. We had to connect digital and reporting systems, we're still doing this, and build value chains so pharmacies could offer choice and consistent supplies. And although the right people can move mountains, one single doubter can slow everything down. At the start, we had to overcome the hurdle of one decision maker who was determined to resist this change. We learned 2 important lessons. First, we needed multiple partners to buy into this shared vision, as Cletus described in West Africa. And secondly, to innovate within governments, we needed to build trust and work together across multiple arms of the ministry, not just with one program or contact. Fortunately, our single resistor moved on, and we are very fortunate right now to have great leadership at the Ministry of Health. But to support commercializing the supply of self-injectables, which is a promising new technology, we worked with the ministry and professional associations to train almost 500 pharmacies and digitize the curriculum so we can enable rapid scale-up of the pharmacy model. Pharmacists learned to start talking to women about contraceptives when they came in for other items. They offered women a safe, private space for contraceptive counseling. And we checked in with them every month to help with problem solving and supported some of them to adopt social media marketing, which proved to be effective in getting the word out. Women began to tell their friends, and as demand grew, pharmacies took ownership of their supply chains. Within months, more women were coming in for contraceptive injectables in our partner pharmacies. And most importantly, pharmacy owners and operators started to understand how important offering quality family planning services could be for their business. Fast forward to earlier this year, with our global funding cuts causing a significant gap in family planning financing, our heartbeat has taken a shocking blow. Fortunately, we have some hope. Kenya can now explore multiple initiatives, scaling up family planning through pharmacies, exploring how our new social health insurance fund can reduce out-of-pocket payments, and investing in domestic financing for contraceptives. Thinking outside the box post-pandemic has shown us that as a country, we can be resilient, responsive, and resourceful. And at InSupply, we're doing our part to explore how to help ministries maximize their resources. In the last 2 years, we've co-created AI-enabled forecasting tools in Kenya and Tanzania with our ministry partners, with excellent results. Data extraction and cleaning takes 15 minutes compared to 2.5 days previously. We can use more data, more robust methods, and we have high accuracy rates for stable methods that have good data. But again, this transition was gradual and called on building trust. Users had to compare processes side by side, validate clean data, and accept the innovation slowly. Overall, though, it's been a success, and we're handing the tools to the ministry. And ministries can now do more with less. I can see a future where pharmacies, clinics, and ministries are all part of the same fabric, and where governments don't just manage donor pipelines, but finance, monitor, and optimize their own resilient supply chains, just like we heard in Mexico. And where women are at the center and can afford the family planning method of their choice and access it conveniently without bureaucracy or bias standing in the way. We're at an inflection point in our industry, like never before. It's time to act decisively and boldly, invest in tools for efficiency so we can do more with less, galvanize a domestic financing agenda to reduce our dependency, and accelerate strategies that help our systems continue to serve women and their families. It's time to invest in our collective heartbeat and to strengthen our supply chain fabric. I've shared ideas for solutions and alternative ways forward, including expanding national family planning ecosystems to include new private players, namely the pharmacies. But the private sector is diverse and has greater potential than just pharmacies. I want to build on the idea of strategic partnerships with the private sector as potentially powerful allies. And I'm excited to invite Mario Alvarez, CEO of DKT Latin America North, to bust the myths and tell us why we are working with the private sector. Mario, welcome.
Thank you. Thank you so much. Hello, I'm Mario Flores. I am CEO of Latin America, DKT Latin America North. Thank you, Jasmine, for an inspiring story about partnerships with pharmacies. You asked me to demystify what the private sector does for family planning. But before that, I would like to just say, what is exactly private sector for family planning? Many of us think of for-profit manufacturers, but there's so much more. It's a broader ecosystem of many actors that include social marketing organizations, social enterprise, private sector clinics, and pharmacies. Logistic firms are private distributors that get the goods from the manufacturers all the way to the point of care. Media and demand generation agencies, all combining, they form a market-oriented network responding to quickly to shifts in demand, scaling distribution, and innovating. I would like to tell you two stories about private sector partnerships. The first one comes from Ghana. When COVID-19 struck Ghana, the Minister of Health in Ghana had faced a huge paradox. On one side, you had women that were extremely concerned about the situation, about contraception, and wanted family planning commodities. On the other side, supply chain was severely constrained because of, border shutdowns, because of logistic complication, donor funding reduction. So cuts, staff changes, it was a hard time. DKT International was the only private sector actor with stock, also both of short-term and long-term contraception. Also, a robust distribution network and the ability to promote commodities and services to consumers. In April 2020, the Ministry of Health awarded us a permit to be able to distribute commodities both to the public and the private sector. We went from short-term commodities to pharmacies and long-term commodities to maternity homes and clinics. So it was a very special time because DKT became a private sector and a public sector distributor. In addition, there was a DKT campaign emphasizing that contraceptive use does not increase COVID-19 risk, debunking social media rumors. Private maternity homes did not face significant stockouts, so it was a huge success at that time. By helping keep reproductive health services functioning, DKT helped reduce unintended pregnancies and maternal mortality during a time when healthy system capacity was stretched. What did we learn? Speed matters. A private sector actor is agile. Flexibility is crucial. The temporary permissions that Ghana Health Service allowed enabled DKT to act as a public and a private sector supplier in a time of need. Synergy, not competition, by purchasing commodities from the public sector and redistributing them to private clinics. And, of course, supported the incredible work that the Ghana Health Service did in times of COVID. My second story is about private sector partnerships in Latin America and the Caribbean. In Mexico and our countries, 8 lakh countries, there is a gap in terms of the public sector with free commodities and services, and the private sector that offer them at a cost, but usually at a higher price than lower and middle income women can afford. And so DKT's strategy in the region is to procure all of the long-term methods and negotiated at a price that we can distribute at a margin that keeps prices competitive. We distribute commodities in partnership with private sector distributors to ensure efficiency and to ensure coverage. We conduct hands-on trainings for service providers, and we use social media and influencer partnership, traditional media, to create a pipeline of informed clients who are then referred to private sector clinics. So this model operates outside the constraints of public budgeting. It ensures availability of LARCs and other reproductive health services, even when donor funding fluctuates. Well, what does the future hold? DKT private sector portfolio is expanding to male-focused services, recognizing, of course, that reproductive autonomy involves both partners. So in Mexico, we piloted a social media-driven campaign that educates men about vasectomy, offers free counseling, and connects them to private sector clinics. This model projects 30,000 vasectomies by 2026 in a small DKT clinic in Mexico. So finally, the key ingredients for private sector success is aligning incentives between all the players, prioritizing collaboration over competition, prioritizing health outcomes over sales, and last, innovation, like a digital demand campaign that we're doing for vasectomy. As a result, all actors are collectively creating a market where reproductive health is not a luxury, but readily available health services that can withstand pandemics and other crises. I have talked a lot about services, but there's a quality that is very important, and that's empathy, an ability to understand and to share what the client wants in her and his healthcare, and design the supply chain that's informed by that understanding. And now I call on my final storyteller, Nadia Olson, to tell us about how some special women made groundbreaking changes to the supply chain, fueled exactly by empathy for women and girls seeking family planning, because of course, where there's empathy, there's always hope.
Thank you. Hi, I'm Nadia Olson, and I've witnessed extraordinary stories of women in leadership. And like all of these stories we're hearing today, and I'm going to tell you a couple. These stories emerge not in boardrooms or conferences, but in quiet moments of trust and collaboration, over lunch conversations, on long truck rides, along rugged and dusty roads, or on the floor counting medicines in hot, very hot inventory rooms, or treks into faraway communities. I'm sure many of you have been on these journeys yourselves. What I'm sharing today are just two examples of the most beautiful stories, but there are so many all over the world. Women transforming healthcare systems against all odds, and ultimately, these women have helped sustain me through my own crisis. My first story is about the pharmacist revolution in Peru. In the corridors of the Peru's Ministry of Health, I had been working with a team of female pharmacists for some time, and we had already made significant contributions to strengthening the health supply chain. These women held positions of authority and expertise that I respected. But it was only after we had built deep trust over years of collaboration that they revealed their incredible backstory to me over a very delicious lunch in Lima, Peru. Years earlier, they had worked as low-level logistics functionaries with very minimal authority. They were overshadowed by male doctors who controlled the institution. Despite their expertise in pharmaceuticals, these women had little voice in decision-making, but they saw what their superiors missed. The ministry desperately needed an information system to effectively manage their health commodities. With determination born from frustration, they had organized themselves and made an extraordinary decision. Each month, they pooled money from their own pockets from already very low salaries. And this was a big sacrifice. And with these funds, they worked with student developers to build the management information system the ministry needed, but would not invest in. Their grassroots innovation became the backbone of the Ministry of Health supply chain management system, saving money and dramatically improving supply chain efficiency. Through this strategic investment in technology, these women didn't just solve a problem, they transformed their own positions. The system they created gave them authority, expertise, and they had the influence now. In the ultimate vindication of their vision, one of these former low-level pharmacists became the Minister of Health. Where Peru's pharmacists worked with existing systems to create change halfway across the world in Yemen, Women were building healthcare from the ground up in places where formal systems had collapsed. In Yemen, remote areas where conflict had devastated healthcare infrastructure, community midwives often stand as the only health workers available. No doctors, no nurses, just these dedicated midwives serving their communities. Their story is one of persistent presence through repeated abandonment. These midwives had weathered cycles of support and withdrawal long before the current crisis. Even before the latest war and budget cuts, they experienced interruptions in support that left them to serve their communities alone. When war erupted, support disappeared entirely, only to eventually return little by little. I had been working with the Yemen team on several iterations of projects through all these interruptions. Over time, we had the innovative idea of creating home-based clinics. The community midwives received equipment, commodities, including contraceptives, and training to establish these clinics, transforming their homes into lifelines in these communities. These female leaders provided essential care at the grassroots level, serving people who would otherwise have no health care. These clinics became beacons of hope in areas forgotten by formal health system. One of my team members, Suad al-Hattari, who had been there through all these iterations and all these interruptions, eventually achieved the remarkable feat of becoming the director of USAID's only and very large development project in Yemen. This took enormous effort. Seeing a woman in this role was the highlight of my career, which had never happened before on such a large project. When the Trump administration cut funding, it was a familiar blow. These vital services faced extinction once again, but the midwives continue providing care on their own, charging nominal fees when possible, driven by commitment rather than compensation. Suad is still there. Like me, she has two sons who are so proud of their mother's beauty and strength and insistence on staying home to weather the latest storm together with the midwives. We will all work together in Yemen again. In the meantime, we sustain our sisterhood. And now my own story. After losing my position in that same wave of terminations, it was not easy to find a pathway forward. Throughout this struggle, I kept these women in mind, the pharmacists in Peru, the midwives in Yemen, Suad al-Hattari, Nora and Yasmin, who are here on the panel today, and Annabella Sanchez, who is not here, but many of you know her. These stories gave me courage and helped me understand that the work is not attached to any single institution. It belongs to all of us who have been working together all this time. Throughout these 7 months, my two sons, Gabriel, who's 16, and Lucas, who's 12, have been cheering me on. They've tightened their belts with me and have shown genuine interest in what I'm doing to find a way forward. My father, Douglas, has also held my hand through this difficult time. My mentor, David, who had also been my boss during early days of this work, left his own job and came looking for me so we could create something new together. This network of male support, alongside all these stories of resilient women, has given me foundation to flourish. I finally landed consultancy work, several new mechanisms I'm building, one of which I'm building with David, called Vital Supply Chain. This new organization will bring health supply chain expertise closer to the people who need it, equipping the experts of the past with technological tools and AI know-how to directly support people on the ground to develop those skills themselves. Finding this pathway forward was deeply meaningful, not just professionally, but personally, in the midst of all the grief and turmoil. The most beautiful moment came from Gabriel. He told me he never doubted that I would find a way forward, just like the women in these stories, stories he had heard many times before. Thank you.
So we come to the end of our stories, and please move to the front of the stage with me, great storytellers. So I wonder what's in the package. Buzz back from the bottom of the ocean. Thank you so much, fellow storytellers. We have two things for you. Keep your courage in good supply. Keep telling your stories. Those stories are formidable agents of change. we always find a way as a community. And so we have an abiding and long-lasting message for you, which is this. We always find a way to infinity.